Okay, thank you, Kathleen. I'm here just to welcome our guest. Her name is Dr. Scarlett Aldrich. She is a plastic surgeon. Oh, there she is, a plastic surgeon at LMH Health. And Dr. Aldrich, I'll let you tell us a little bit about yourself when I hand it over to you, if you will. As Kathleen said, please do put your questions in the chat feature. We just have too many people to ask them, to unmute and ask them out loud. But she does entertain questions while she's talking about that particular subject. Just keep in mind that if you have a personal case, a personal skin issue that Dr. Aldrich probably does not know about your case or your history. But she is willing to take emails with your questions, which I think is a very generous offer. So we will be we'll send her email address to you as a follow-up, along with the link to the recording of today's session, okay? So just keep that in mind as we go along. And without further ado, I'm going to turn it over to you, Dr. Aldrich. Thanks so much for being here today.
Yeah, perfect. Thank you. I am just as excited to see everyone's face. This is great. I can't wait till we can do this in person because I love talking with everybody. I love the engagement and the interaction. So truly, any questions that you have as we go, I would love to hear them. I want this to be useful for you. I want you to get the information that you're looking for. I tried to create an overview of a bunch of general changes in aging skin, but the most common thing you come up with is, you're at a dinner party or getting together for Thanksgiving and someone comes up and says, hey, I've got this spot. Can you take a look? And I'm always happy to do that because all of us have skin and we are all aging. So this literally affects everyone. So anytime that, this sparks a question for you, please insert that because I want to know. Just in general about me, I've been at LMH for going on 3 years now. I came here, this is my first job after years and years of training. I love it. It's amazing. Programs like this really engage our community and make me feel so invested here. I hope that this will be my first and my last job. So I am a plastic surgeon. Oftentimes when you think of a plastic surgeon, you think of Dr. 90210, a cosmetic surgeon who only focuses on those sort of things. But honestly, taking care of skin lesions is a huge part of my practice. It's something I see every single day, multiple patients. Sometimes it's something very simple. Sometimes it's how to prevent aging. Sometimes it's a skin cancer. It can be anything. But that's a huge part of what I do, along with my partner, Dr. Keller. So, we were mentioning earlier the difference between a plastic surgeon and a dermatologist. You got a spot on your skin. Who do you go see? Sometimes that's community dependent. In our community, we are very limited in terms of our dermatologist, and oftentimes patients can come and get in to see me or my partner sooner than they can get in to see a dermatologist. And sometimes time is key. So wherever you can get in, the sooner you can get in, I'm always happy to take a look at a particular spot or concern. So let's go ahead and get into things. I'm going to share my screen. And like I said, any questions you have, let's go along with that. Okay, are we seeing the screen as it should be?
Yes. We are.
Okay, perfect. So like I said, this is a collaboration of multiple common changes in aging skin. So let me see if I can get this started here. The first thing to think about in general is aging skin physiology. And there's a lot of information here. It gets very in-depth, very sciencey, but essentially what I wanted you to know is that there's two different things going on. There is intrinsic aging, which is happening between the cells, regardless of your environment that you're in. There's impairment of the communication between the cells. There's a decrease in cell turnover or doubling. So a decrease in the cell's ability to renew itself, if you will. And at the same time that we have fewer cells renewing or being created, we have an increase in the number of cells that are being broken down. This can lead to impaired nutrient transfer between cells. as well as a decrease in collagen and elastin amongst other cells in our skin. The thing about collagen and elastin is that that is often responsible for the common outward appearance of aging, including wrinkles or looseness of the skin. And I put this little stat in here because I always find it shocking. You know, my grandma always told me, you're not old until you're 80. And I really took that to heart. I really believe that. And what I have found is I'm already experiencing a lot of these skin changes, and I'm 35. And the reason for that is because things are already changing. We are aging every single day. So after the age of 18, we lose 1% per year of elastin and collagen, which is kind of interesting. Makes me already feel a little behind the 8 ball, but that's okay. The combination of this intrinsic aging leads to thinning of the dermis. There are 2 layers of your skin. The outermost layer is the epidermis, and then the thick layer of our skin, which really does most of the work for us, is our dermis, but that gets thinner with time. You'll notice that your skin becomes more fragile, you bruise more easily, and wounds take a little bit longer to heal. So that's one side of the story. The other side of the story is extrinsic aging. So there are environmental factors that are also going to play a role and compound the aging that is already happening in our cells. Pollution, UV radiation, chemicals, smoking, all of that is going to play a role here to increase cell damage, decrease your body's ability to repair that damage. It also creates an inflammatory state within our cells and breaks down collagen and elastin. So that leads to wrinkles, some of the skin changes that you see at the bottom that we'll go through in a little bit more depth here as we go. So first off, dry skin. Dry skin is a common thing that happens as we age. You may not have changed anything that you do. You may use the same face soap or moisturizer that you used 30 years ago, but something is different. Your skin is just dry and it's not necessarily seasonal. So things that you can do to prevent this or help with this is staying hydrated, drinking plenty of water and fluids each day. A humidifier can be really helpful, particularly in the dry winter months, using topical moisturizers, lotions, and they're not all created equal. Sometimes it's a matter of what your skin can tolerate. Maybe you need something that's not going to cause a lot of irritation, commonly like Aquaphor or Cetaphil, Aveeno, some of the sensitive skin moisturizers. And also what's going to last the longest. Aquaphor is one of my most favorite things. On that movie, My Big Fat Greek Wedding, you know, one of the relatives uses Windex for everything. That's me and Aquaphor. I use Aquaphor for everything because I think it's just very well tolerated. It's Vaseline based. So it stays on your skin and keeps you moisturized for longer without making you really oily. So if dry skin is a real issue for you, this is a good option. Also using mild soaps if you're going to. Oftentimes, you know, when you talk with dermatologists, they say we wash our skin way too much. We shouldn't be showering and washing our skin daily with soap. Really, every few days is fine, and just using soap on the important parts under the arms, in the groin is best, and just water for the rest. And then finally, using warm water instead of hot. I haven't completely jumped on this train yet because I really like a nice hot bath or shower, but it is an option that would certainly be helpful if this is an issue for you. It's important to take care of your dry skin because dry skin can become itchy skin. Itchy skin, if you're scratching, can lead to increased damage, which when you have thinner skin or skin that's easier to bruise, can just compound on itself, creating wounds and then difficulty healing. So although it seems simple, it is an important component to pay attention to. Like I alluded to, easy bruising. The blood vessels within the superficial skin become more fragile. So they are breaking more commonly without trauma that even seems significant. You may, in fact, have no idea where a bruise came from. And then the thinner skin makes that bruise more visible. If the skin is thicker, you may not even see it as much, but with very thin crepe-like or tissue paper skin, you're going to see it quite a bit. Best thing to do here is to avoid trauma as best you can. Be careful with your body. And local wound care is important if the skin is broken. What does that mean? That means keeping that area clean, using a soap. One of my favorite soaps for wounds is called Hibiclens. If you've ever had surgery, oftentimes we will send you to the store to buy some Hibiclens. It's over the counter. And we have you wash with that to get rid of the bacteria on your skin in preparation for surgery. So that's one of my favorite soaps to use to keep wounds clean. And then applying some bacitracin or Aquaphor to that wound and keeping it covered with gauze so it doesn't endure any additional trauma is helpful. Another thing that we talk about quite a bit for bruising is something called arnica. This is also over the counter. It is more of an herbal supplement, and we don't have concrete research that says that this helps, but anecdotally, we have found that arnica does help resolve bruising more quickly. You know, this may not be something that you would use on a bruise that you have on your leg or your thigh, but if you fell and had a bruise on your face and it really ended up looking quite dramatic, as it sometimes can, arnica can be something that's helpful to help resolve that more quickly for you. Wrinkles. This is a big one. Again, this is a result of the aging process. This is something that we all get. There's no way of avoiding it, only slowing it down. So the first thing is limiting sun exposure. UV rays have undoubtedly some toxic effects on our skin. That being said, the sun is also a beautiful thing for us in terms of getting vitamin D, in terms of boosting our endorphins, boosting our mood. So you're never going to hear me say, don't ever go out into the sun. It's just that you have to be smart about how and when you do it. So limiting sun exposure during the peak hours of the day is good, especially in the summer, and wearing sunscreen every single day. A lot of people only wear sunscreen in the summer because that's when they see the sun most prominently. The problem is that there are UVA rays and there are UVB rays. UVB rays really spike up in the summer, and we see that and we feel that. UVA rays stay consistent year round. The tricky thing about those is they can penetrate your windshield, they can penetrate your windows, and they are still causing damage to your skin, even if you're not outside. So truly using sunscreen year round is helpful. I just make it a part of my daily routine in the morning if I'm going to go out. You also have to remember there are a couple sneaky parts of our body that I feel like we always forget to put sunscreen on. We're good at putting it on our face and our neck and the rest of our body, but we often forget our ears and the backs of our hands. And I very commonly see skin cancers pop up specifically in those areas. And I think it's related to that.
I have a question about that, doctor.
Sure.
Skincare SPF recommendation. I mean, sunscreen SPF recommendation.
Yeah, so it's the minimum is 30. There's a 30 SPF. We don't have research to say that if you go up to 100, that's going to be so much better for you than 30. So 30 is a solid SPF to use. The trick is reapplying. So if you're going to be outside consistently, every couple of hours, it's going to be a good idea to reapply that sunscreen.
And when you're wearing, when you're being really good about your sunscreen, does that limit the vitamin D from absorbing into your skin? I read that it might. I'm just not sure.
It's a good question, and we don't have a specific answer for that. Could it? Sure, if it's blocking some of those rays, but the likelihood is that we aren't that good at putting on our sunscreen. So we will get that vitamin D regardless. Now, that being said, vitamin D levels are something that can be tested for with your primary care doctor. And if you are found to be deficient, it's something that can be supplemented orally to help.
Okay, thank you.
Yeah. Avoid smoking for a bazillion reasons, but wrinkles as one of them. Smoking is one of the worst things that you can do for your body, both inside and out, but you can certainly tell the difference in somebody's skin who has been a smoker for the majority of their life and who was a non-smoker. I think if you look at twin studies between the two, it's dramatic, the difference that makes in terms of facial aging, particularly. Skincare regimen can also be really helpful in terms of rebuilding collagen and elastin. This is dependent on you as a person as to whether this is something you're interested in or not. For a long time, I had no interest in taking care of my skin. I would wash it and put on some moisturizer and call it good, maybe some sunscreen, because again, I didn't think I was going to be old until I was 80. So I thought I had lots of time to deal with that. Now, that being said, I've already got some dark spots. I've got some wrinkles that are coming in. And I said, okay, maybe I do need to jump on this sooner than later. So there are many products in a good skincare line that can truly help rebuild the collagen, the elastin in your skin, help decrease age spots, help decrease wrinkling. My only caveat here is that if you are genuinely interested in a skincare regimen, that you come to a plastic surgeon's office as opposed to Target and Walmart and get inundated with all the different options that you have for skincare that may or may not actually work.
We do have a question about collagen protein supplements. Are they a good idea or a waste of money? Angie wants to know.
That's very interesting. And that's actually something that I have been looking more into actually very recently, in terms of the last couple of weeks, because there is a lot of new research that is showing that collagen protein supplements are actually very helpful, and not just from this standpoint in terms of externally what you're seeing, but decreasing the inflammatory load and response within your body. So there is a lot of research that is coming out that says that that is beneficial. And I personally have just started supplementing that in my own diet.
Okay, thank you.
Other options for wrinkles, things that I see very commonly, is using filler or Botox products. So Botox, the way that works is it paralyzes the muscles to prevent them from creating wrinkling. Botox is most commonly used in the upper face. So used for the crow's feet here, the 11 lines between our brows, and then the lines across our forehead. It works beautifully for that. The sooner that you start using it, the better it works in terms of it truly is preventative. So if you stop those muscles from firing all the time, they're not going to make the creases as deep as what they were if they would just keep going on and on. So I started using Botox in my training as a part of a learning opportunity and have very few wrinkles. Versus my mom, who was also my number one test subject when I was learning, had never had it and had more deep set lines when she was 55 than what I did when I was 30. So it is something that can really certainly help, but it's a temporary solution. It's something that has to be redone about every 4 months or so. Fillers we use for more of the lower face. Oftentimes the lines that go from the corner of our nose to the corner of our mouth are in the lower face. And the goal with the filler is to restore volume that has been lost with time. Our skin thins, but we also lose the thickness of the fat layer underneath our skin. When you look at a little baby, they've got, rolls on rolls, and they, have a very convex face because of the amount of fat that they have. But then as we age, you see things really shrink down. The face becomes a little bit more sculpted, if you will. And as we age even further, can become essentially hollow in places. So filler can be useful for that. Filler, how long it lasts depends on the type that you use, but typically about 6 to 12 months.
We have another question. This is about collagen, so I wanted to ask you now.
Sure.
Is collagen like Botox sort of more of before the wrinkles happen, used to prevent them, or can it actually help ease wrinkles?
So again, I don't have enough research to say that it can reverse the wrinkles that we have already. at baseline. I think Botox works much, much better. It's a much more direct route for that. But I think that there is some role in prevention for that, for the collagen.
Okay, thank you.
Laser therapy is another option for wrinkles. It essentially creates damage in the skin that then kind of jumpstarts your own system for repairing that damage, creating new collagen, new elastin to repair the damage that has been done, which helps tighten the skin. But there are a multitude of different kinds of lasers that can be specific to color change or dark spots, wrinkles, or even the little red spots that we get from little blood vessel collections in our skin. And then, of course, surgical procedures, a facelift, neck lift, getting rid of excess skin and wrinkles on a variety of parts of our body. That's also an option. Obviously, the most invasive of all of these. Skin tags. These are super common. They're often in areas of friction. So they're going to develop with time because we get more and more friction as we age, just from repetitive trauma. So you can see this gentleman around the neck. They often get that because our shirts are rubbing on our neck, or jewelry, necklaces, armpits where our arm rubs, groin, underneath the breast, eyelids even. I've taken several off the eyelids. These are painless, they're soft skin lesions. They often have a little stalk. So they may seem bigger at the tip, but then they kind of come down to a little stalk at the base. Sometimes they're just as tiny as like fabric pills. When you're wearing pants and the pants rub together and they create that pilling, that's often how skin tags can appear. It's a similar philosophy between the two, just the extra friction. These are totally benign. These are not something that's ever going to cause you cancer. This is not something that is going to create an issue from that front. However, they can become inflamed. They can be painful from consistently being pulled or getting caught. So for that reason, as well as just aesthetically that people don't like them, I often see these and take these off. We have a couple of different ways that we can treat these. The most common that I use is excision, where I just put a little bit of local anesthetic right there and snip it off. And that's really it. Typically does not require even a single stitch, just a Band-Aid, and it heals up with time. Another option is cryotherapy, where if you've ever had a wart and you went into the doctor and they froze it with a cryotherapy gun, that's another option for skin tags. You freeze it, and then with time, it falls off. Ligation is also an option where you would tie off the base, tie off the blood supply, it would die and fall off. But that just seems like I don't know, in my mind, a slow, painful death and the least effective or time efficient way to do skin tags. So I don't do that. Solar elastosis. This is a fancy term for that leathery, thick, wrinkled skin. It can also be kind of yellowing in appearance. This is due to long-term sun exposure. So you're thinking farmers, fishermen, gardeners, people who have been outside, spend a great majority of their time outdoors. It can also be seen prematurely in smokers, especially this appearance that we see around the mouth. That is often a telltale sign of a long-term smoker. So again, treatment here, prevention, and that is sun protection. So wearing sunscreen when you're out, protective clothing when you're out, avoid smoking. And then again, once it has happened, we go through the same philosophy, talking about skincare, filler or Botox, laser therapy to resurface the skin, etc. Once the lines are super deep set like this, it's going to take multiple treatments and probably from a variety of approaches to really get this to soften up.
We've got one late question on the skin tags. Will they grow
Sure.
back after they're removed in that
No.
spot? Okay.
So that particular skin tag will not grow back. Now, that being said, you could develop more because you're still going to have an area of friction. So more could develop, but they don't recur.
Okay, thank you.
Seborrheic keratosis. This is a super common skin finding. I think it's a really important one to take a little bit of time to understand because they look scary. I remember being on the beach, just starting my medical training, so I didn't really know much of anything, but I saw one of these on my aunt's back that was about the size of a nickel, and I thought, oh my God, you've got skin cancer, you've got to go see someone, this is emergent. Turns out these are totally benign. And I'm sure she went to her doctor and said, oh, my niece, she's in medical school. She knows what she's talking about. She said this is cancer. And they probably laughed and said, yeah, she's got a lot of learning to do. But they look scary. They can be irritating. They can get inflamed, red, itchy, but they are completely benign. They are waxy in appearance or scaly. They have a rough surface. They're raised off of the skin. You can feel it as you move your hand across your skin. They can be really dramatic in color, like this brown, black color that you see, but they can also be more skin colored. You know, in this picture in the top right, you can see the two that are very obvious, but then all those little small ones in between, they may not be as visible, more just that you can feel those. So like I said, these are not cancerous, but they can become inflamed. They can cause problems the same way that skin tags can. They can also continue to grow and become more numerous with time. So oftentimes I see these for excision. So if someone were to come in and we had these isolated lesions like you see in the top right, my recommendation most likely would be direct or shave excision, where I would numb up underneath that lesion, shave it off flush with the surface. The body heals that over with time. It will scab up, crust, and be done. And that's all. If the patient came in like what you see on that top left, where they're so numerous that would be too intensive to do, we may do that to the most prominent ones, but then we may consider cryotherapy of the rest. And again, that's going to be freezing these lesions and letting them fall off on their own. This may require multiple times. Typically, I'll freeze these and then reevaluate them at a month. And if we need to freeze them again, we can, but that's also very effective. There have been times when I have seen these so large that the best option is to actually directly excise them, you know, kind of cut a football shape out around it and close it edge to edge with stitches. But that is not the most common way of doing things. You may hear of other people talking about cauterizing these or burning these, but I think that cryotherapy works just as well and is less painful. So I typically do not do that.
And will these grow back?
So no, they won't. But
Okay.
similar philosophy again is with the skin tags, as though this specific lesion may not grow back, but you still may develop more on other parts of your body. Why they come up, it's hard to say. Some people are just more predisposed to these than others, like this gentleman on the top left.
Do they need to come off though, doctor, if they're not
No.
bothering you? No.
No,
Okay.
they don't. They're not cancerous. Unless they give you trouble or you don't like the looks of them, we don't have to do anything with them.
Right.
The only potential risk is that, especially if they're in an area where they're also going to be rubbed a lot or have a lot of friction, they could become inflamed or infected, and that could cause a problem.
Okay, thanks.
So a solar lentigo, often caused by, again, just time, aging, sun exposure, often called an age spot, or in older terminology, a liver spot. Again, I didn't think I'd have these until I was 80, but here I am. I've got multiple of these. This is just a part of spending time outside, enjoying that without, you know, necessarily protection. So limiting sun exposure, using sunscreen, those are going to be very helpful. Again, skincare specific to these dark spots can be very beneficial and very effective. Something called hydroquinone is a topical that we can put on like a lotion or a serum. And that's the gold standard for these. And it works incredibly well to help minimize the appearance of these spots. You can also, again, do laser therapy, which is more of a heavy hitter. When I think of the difference between skincare and laser therapy is something that you're going to do if you want a bigger and a more quick response. You've got a wedding coming up in a couple of months and you've got this one spot you really just want to get rid of so it doesn't show up in your pictures. Those are the patients I recommend to have laser therapy, versus somebody who says, yeah, I just don't like the way that these spots keep popping up. I want to soften this. I don't want them to stand out as much. Then we work on skincare. Skincare takes patience and consistency, but with, consistent use over a period of a few months, you will see a change here.
Can you get the hydroquinone over the counter?
So you can get some versions of hydroquinone over the counter, but they are of a lower strength. Therefore, they are not going to be as effective. If this is something you really want to work on, 4% hydroquinone is what we go for, and that's a prescription strength.
Okay.
That you would get like from our office or another dermatology or plastic surgery office.
And then we just had a follow-up to the liver spot. I mean, what causes them? That's the sun as well, right?
Sun damage, yep. Sun damage,
right.
And as well as intrinsic aging.
Sure, okay.
Yep. So next up, we start getting into sort of the darker side of the skin lesions. Everything that we've talked about up to this point can be an irritation, it can become an inflammation, or just, sort of an eyesore. But the things that we're coming up onto now are the ones that really catch our eye, things that we do have to do something about. So first, I'll talk about pre-malignant lesions. Pre-malignant means precancerous, meaning if these spots are left unchecked, they could become cancer down the road. So it's always better to get to things earlier than later. So when these things come up, we definitely want to take care of them. So the first is something called actinic keratosis. This is very, very common. I see this all the time. That's what you see in this top left picture and top right picture. The skin, it looks red, sort of scaly. You can see it's almost like it has a little scab on it or a dry patch of skin, but it just won't go away. That is most likely an actinic keratosis. The top right picture that you see of this gentleman's scalp is super common. I see this all the time because, again, you're not necessarily thinking about putting sunscreen on your scalp. You don't always wear a hat. So it is right there, just the sun bearing down on you. And the other issue with this is that it's really hard to see your own scalp. And by really hard, I mean you can't. You can try to take a picture, you can try to look with a mirror, but that can be difficult. So oftentimes you're relying on the way that feels, and that rough scaliness is something to have evaluated. Because for actinic keratosis, about 10% of these can go on to become cancerous. So when they're at this stage, I can freeze it with my freezing gun, kind of a quick and easy office procedure, versus once this becomes cancerous, I'm going to have to actually cut it out. In the middle pictures right there, this is something called a keratoacanthoma. It's a smooth dome, and in the center, it has this little crusted or hard core or horn. It oftentimes grows very quickly and then suddenly resolves. So you may notice, oh man, this is weird. I've got something going on. I better call and get into the office. And then weeks later, when you show up for your dermatology appointment, it's gone. You're like, I swear there was something there. Most likely that's something called a keratoacanthoma. Patients who come in with these are most likely to get these excised, especially if they're large. We treat them like a squamous cell carcinoma, which is what SCC stands for, to get rid of them. And because sometimes they're difficult to delineate which is which. And then on the bottom there is something called a cutaneous horn. And this is truly like a horn or a fingernail type substance that grows and projects from the skin. These can be painful, they can be irritating, especially when they're big, like what you see here. And most concerning is they can be cancerous at the base. These are more rare. I haven't seen a ton of these, but I can tell you the last one I saw was on a gentleman's ear, and it protruded probably a centimeter or so. So it got caught on things, got caught on his hat, pulled, became very sensitive and tender. And whenever we took it out, sure enough, it had a squamous cell carcinoma along the base of that rim. So if you see something like this is certainly something for us to take a look at and take care of. Basal cell carcinoma. So this is a cancer. In fact, it's the most common form of skin cancer. There are a variety of kinds of basal cell carcinoma, so it doesn't make it always so easy for you to identify. But the most common is nodular basal cell carcinoma, which is what you see in that top row of photos. So it's usually well defined. You can tell where the lesion is and where normal skin begins. It's often flesh colored, or it may have little tiny blood vessels, or what we call telangiectasias, that make it look a little pink or red. It can be pearly along the borders, like shiny. And oftentimes it can also have a little indentation centrally. So what you're seeing there on that top row are very, very common presentations of a basal cell carcinoma. The second most common is what we call superficial spreading basal cell. And you see that just next to that description. It's more flat, pink, scaly, may have ulcerations or crusting, may look very similar to what we just saw as an actinic keratosis. So the difference that I see in these is that this one's more crusted, it's more well-defined. This one looks more suspicious to a trained eye. So this is most likely not going to be frozen. This is most likely going to be biopsied. The other option is if we're just not quite sure which one it is, we could either err on the side of biopsy, let's find out, or err on the side of let's just freeze it. Let's do less is more. But if it's still there in a month, I'm probably going to biopsy it. Another type is a pigmented basal cell, which is what you see right in the center of that screen. These are particularly tricky because when you, as a physician, see a dark lesion like this, the first thing you're thinking is melanoma. It's not basal cell carcinoma. So this is always going to get a biopsy to find out exactly what we're dealing with so we can treat it accordingly. Because treatment for basal cell carcinoma that's pigmented versus a melanoma is very different, as you'll see here. If it's a basal cell carcinoma, I just have to get around it, make sure my margins are clear, and then we're done. Margins are clear, meaning that none of the lesion is touching the surrounding skin. I've got normal skin on both sides, and then I can close that together with stitches. The last kind of basal cell that I'm going to mention here is the worst kind. It's called a morpheaform basal cell carcinoma. This one is tricky for a couple of reasons, but mostly because it is hard to identify the borders of this lesion. So if you look on the far bottom right, you can see that something looks different there. Something looks off about that skin, but it's more flat and it almost is scar-like. Even though you may have never had any trauma in that area, you don't have any reason to have a scar. If something looks off, go get it checked. That's what I can say about any of this stuff. If it's benign, great. If it's, we don't have to do anything with it, fantastic. But if it's something that's actually like this is the most aggressive kind of basal cell carcinoma and is going to require us to be on top of it to get this out. Okay.
We do have a couple of questions. One, I think, is started back on the page before. If something grows and then resolves, should you still be concerned?
So in speaking about this keratoacanthoma, something like that it grows, it's really fast, and then it resolves and it's completely gone. No, it's not a problem. We don't have to do anything with it.
Okay. And then do you do Mohs surgery? M-O-H-S.
So that's a great question because that's a common one whenever we talk about skin cancers. So what Mohs surgery is you're going to come into the facility They're going to numb up the area of concern, and they're going to go right around the edges of it. They're going to take as little as they possibly can. They're going to go back, look at it under the microscope right then and there, and see if they've got the borders are clear. If not, they go back and they shave a little bit more and they check it. And is it clear or is it not clear? Then they go back and take a little bit more, kind of back and forth, until they have taken everything that is cancerous, but hopefully minimize as much as possible anything that is normal. And then that gets closed up. Sometimes the person who's doing the Mohs surgery will close it themselves. And sometimes it'll be a delayed closure where they coordinate that with a plastic surgeon who would see them the next day or within the next few days and close that defect. Mohs surgery is really good for areas that are cosmetically sensitive, say an eyelid or on the lip or on the border of the nose or even on the ear, areas that are cosmetically sensitive that we also don't have a lot of looseness of the surrounding skin. Mohs surgery is really helpful for. I do not do Mohs surgery in my office. I do something called frozen sections, which is essentially sort of a slow Mohs. What I do is I bring you in. If it's an area where the lesion just isn't really well defined, I can't see the borders of it perfectly, or if I'm in an area of cosmetically sensitive parts of the body, then what I'm going to do is I'm going to numb it up. I'm going to take right around the borders and I'm going to send it to pathology. And you're going to sit and wait while our pathologist, as opposed to me, look at it and see what our borders look like. If our borders are clear, then I get to close it right then and there. If our borders are not clear, I take a little bit more. The benefit of that is that as a plastic surgeon, I have a lot of tools in my toolbox to be able to close that on the exact same day and the exact same procedure so that when you walk out, things are done. The downside is that it's going to take a little bit longer from us to wait for the pathologist to read it and then come back to us.
Do you know if we have a Mohs surgeon in town?
We don't.
We do not. Okay, thank you.
Nope. Okay, the next one, second. Sorry, did you have another one?
No, I just made a noise.
Okay.
I'm sorry. I should have muted myself. I just was having a little reaction to that foot. I will mute myself now. I'm sorry.
Yeah, that's a humdinger. We hope to never see that. This is squamous cell carcinoma. This is the second most common skin cancer. I see this one all the time as well. So this is going to be a red or scaly patch. It can be not nodular or built up on the sides. It can have an open wound. It can even be a wart-like growth. This is something that people come in, they say, well, I don't know, maybe I cut myself, or I thought it was a spider bite. I'm not really sure. I don't know how it came about, but it just won't go away. I've been working on it, but it's been there for a couple of weeks and it just doesn't seem to heal. Or maybe it bleeds, I barely touch it and it's just bleeding, or it seems like it's getting better, but then it comes back. Any of those things with any skin lesion in general are very suspicious. When that is the case about a skin lesion, you need to come in, you need to be evaluated. We need to take a look at it because most likely there's something concerning going on there. There are multiple different types of squamous cell carcinoma. What you see at the top, those top three, are very common. That is the most common presentation of what a squamous cell carcinoma is going to look like. But there are other presentations as well. Underneath that fingernail is something called a subungual squamous cell carcinoma, much less common, but it can happen. Again, if your nail is abnormal and it looks like this, and this is persistent, something to have checked out. The heel wound that you see here is something called a Marjolin's ulcer. So a Marjolin's ulcer is the development of squamous cell carcinoma within a wound base of a chronic wound. So this may be seen in old burn wounds. This can be seen in pressure ulcers, wounds that have been open for a really long time. They've been in a constant state of inflammation and disrepair. The squamous cell carcinoma can develop there and create a bigger problem like this. This is not something that I would handle. This would be something that I would send more to like KU to be handled. This is a much bigger issue than something I can cut out and close in my office.
I have a question about the bleeding. Are you talking about unprovoked bleeding, like just spontaneous bleeding? Or
It
when
can,
when you
or
scratch something and it,
yeah. So oftentimes it's just something very minor. So if it's on the face, you just wiped your face and then it bled, or you washed your face, or you washed your hands and that lesion just bled. You barely scraped up against it with your clothing and it bled. Yeah. So treatment, we've already kind of gotten into. So we talked about surgical treatment. If it's in an area that I've got plenty of extra skin and it's not necessarily cosmetically sensitive, I can broadly go around that, close it up with stitches, and that's pretty simple. When we get to facial lesions, on the ears or on the hands, and I have less skin, I'm going to be a little bit more creative. Sometimes I'm borrowing skin from other areas and just rotating it in to close a defect. And sometimes it's a skin graft if need be, but the great majority of the time, I'm able to get these closed just edge to edge. Mohs surgery, which is what we talked about earlier. There's also an option for just destruction of the lesion, not necessarily cutting it out, but destruction of the lesion just in situ there by either kind of scraping it out, what we call curettage, and then electrodesiccation, which is cauterizing it or burning the base. That can be used for small or low risk lesions, especially in someone who may not be able to tolerate a surgical procedure. And cryosurgery is also an option in terms of freezing the lesion. May require multiple treatments, but that can be done. And then there are also medical treatments, topical creams, radiation, chemotherapy, etc. I would not say that those are our most common options, other than the topical creams. So that gentleman with all of the scalp lesions that they're widespread, or someone who has that up and down their arms, that instead of treating each individual lesion, using a topical cream, sort of a chemotherapy cream, can be very helpful. That's something that a dermatologist specifically would do, not me. Melanoma. This is the big bad boy of skin cancers. So in terms of assessing lesions, again, anything that looks pigmented always catches my eye. For yourself, if you see a lesion that catches your eye in terms of pigmentation, here are some other ways to evaluate that and see if it's something that needs to be looked at a little bit more closely. So these are the ABCs of melanoma. So A is asymmetry. One side doesn't look the same as the other side. Borders, irregularly shaped borders are also concerning. C is for color variation. As you can see in all of those lesions, they're not uniform, right? A mole is just going to be the same kind of pigment all the way around. These, you have areas that are darker or lighter. That is concerning. A diameter that measures greater than 6 millimeters is concerning, as well as evolution. This doesn't look like how it used to look a month ago or a year ago. Any of those features in a skin lesion, if you walk into my office, gets a biopsy. The important thing to know about biopsy is this. Treatment of melanoma is dependent on how deep the melanoma is, not how wide it is, how ugly it looks, how deep it goes. So you may have a tiny lesion on the surface that goes very deep. That is going to be more aggressive. That's going to require more aggressive treatment than a lesion that is superficial and spread out on the skin, looks bigger, looks scarier, but isn't penetrating deeply through the skin. So when we are biopsying these lesions, I think it is my opinion that the best option is either a punch biopsy or an excisional biopsy. There are demonstrations here with that green device in the center of the slide as to what a punch biopsy is. It's a circular knife that goes straight down all the way through the skin so that when we get a little core of that tissue out, we can truly measure the depth of that lesion. So we have an accurate representation of this lesion. Excisional biopsy is just going all the way around the lesion and taking it out as one. So if I have a small pigmented lesion, I'll just take out the whole thing. If it's larger, I'm going to do a punch biopsy of a couple of areas of it to get that true depth. That gives me a much more accurate representation of what this melanoma is and therefore how to direct my treatment. The other option for biopsying these lesions is something called a shave biopsy. And I just want to caution every single one of you who has a pigmented lesion when someone tries to give you a shave biopsy. It is quick, it is easy, and in a very busy office, that's oftentimes what they're going to do. They're going to do the quickest, the easiest option. Just shave that off of there and let's send it in for pathology. The problem is on the back end of that, because if they just scrape it off, there still may be some left in the skin. We may not have the true depth of that lesion. So when pathology comes back and it says, yeah, this is melanoma, this is a problem, I still need more information to treat it. And I can't just go back and cut out more and add 1 to 2 and get our final depth, because there is change in the healing and the scabbing process. So to be accurate from the get-go really helps guide what I'm going to do, because it can be the difference of having to take a 1 centimeter margin around a lesion and potentially still being able to get that closed, to having to take a 2 centimeter margin all the way around that lesion that I can no longer close, and I have to do a skin graft or something like that just because we didn't have an accurate depth from the get-go. So shave biopsies are a bit of a nemesis for me, as you can probably tell, because I don't think it gives us the best option for the patient and potentially puts you at risk of having to have a more aggressive surgical procedure than what you needed to have. The other thing that's important about melanoma is it can go to your lymph nodes. The likelihood of a basal cell or a squamous cell going to the lymph nodes is much, much lower. With a melanoma, it will be important that whoever you're seeing is not only looking at this lesion and evaluating that, but also checking for surrounding lymph nodes in the neck, in the face, under the arms, in the groin, depending on where that lesion's at. So that's also very important. Once we have that information back, we're going to make a plan with the medical oncologist as to how we're going to treat this. And sometimes that's just surgical excision of the lesion. Sometimes that includes a lymph node biopsy or dissection of the lymph nodes, removing multiple lymph nodes. Sometimes that includes chemotherapy, immunotherapy, or radiation therapy, as well as regular follow-up, evaluating your skin for any recurrence or additional lesions. As you've kind of picked up on this, prevention is the best treatment, making sure that this doesn't happen because of any of your influence is the best way to get about this, but that's often not what we get. Sometimes our first knowledge is when we have a lesion. If anything looks weird, anything looks unusual, it has changed, you're concerned about it, just get it checked out. Call in, get an appointment. Let's see what's going on. If it's nothing, good for us. If it's something, catching it early is our best option. That is all the information that I have for you guys tonight. I'd be happy to answer more questions. They've been great throughout.
Thank you so much. That was excellent. You're very good at that, by the way.
Thanks.
And yeah, so I don't know if anybody, yes, you're getting applause. This is what we do.
Yay.
We do, mime applause.
Do you want me to stop sharing my screen?
Yeah, that might be good. We will, as I said earlier, we will send you a link to the recording of this program. I don't know that it's going to come tomorrow because we're all pretty busy planning for the fundraiser, but it might. We'll send you the link to the video on our YouTube channel, and we will include Dr. Aldrich's email address in case you have any follow-up questions for her. I don't think she would mind telling you that she's expecting baby number 3 in 6 weeks. Yeah. So there's a window of time we have there with you, and we wish you all the best with that, of course. And we'd love to thank Allison Kuntz from LMH Health. once again for helping us find Dr. Aldrich and arrange this program for us. So thank you, Allison, very much. And if you all don't have any more questions, at least for now, here's one. What is dermabrasion / microdermabrasion?
So essentially that is, for a very simple way of explaining this, if you were to take sandpaper and rub it on the skin, that abrasion that it causes, that's dermabrasion. Doing it more delicately or with finer sandpaper, if you will, is microdermabrasion. The goal is to, again, induce injury or create injury in the skin that really ramps up your body's own response to say, hey, let's get over here. Let's rebuild some collagen. We've got to repair this wound that we have. The goal is anti-aging, decreasing wrinkles or mostly fine lines and wrinkles. This can be particularly helpful for those fine lines around the mouth or even the deep lines, because those are hard to treat otherwise.
Okay, I'm going to go one more, and then I didn't realize we were right at 5 or at 5:02, guys. So, but this is something I'm sort of interested in too. What are those tiny little blood dots that show up? Like, I don't know if it's a fair skin thing or like on your legs, for instance, just tiny little red spots.
I should have thrown that in there. They're called cherry angiomas, and they're just a tiny little collection of blood vessels. There's no particular rhyme or reason for them. Again, some people are more prone to develop them than others. They are not harmful. They are not cancerous. And the best treatment for those is actually laser therapy that targets blood vessels, a quick zap, and it shrinks up and goes away.
Okay, thank you so much. I think that's going to do it, everybody. Thanks for coming. We will see you next month is bones, Kathleen?
I think so. I think that's
Allison,
right.
Allison is nodding. Next month
Yes.
is bones. So
March
knee
30th with Dr.
March 30th.
Houston.
Okay.
okay, knee bones connected to the thigh bone and all of that. All right, well, have a good night. Have a good night.
Yeah, perfect.
Thanks,
Thank you,
everyone.
guys.
We'll see you at the
Thank
next
you.
one. Thanks, Doc.
Thank
See you at the next one.